Thank you. Good evening. I think the purpose of the discussion was to be pretty frank about health policy reform in South Africa, and I intend to do that. Just in terms of some background on myself, my background's in health economics and financing. I was previously at the Center for Health Policy. I was part of the transition team that put together the Gauteng Department of Health in 1994. I've also ran the finances for the Gauteng Department of Health around about 3 years to kind of turn around the financial crisis at the end of the 1990s and into 2000. And was also part of putting together the regulatory framework for medical schemes, part of the Taylor Committee of Inquiry, lead economist on the health market inquiry until the end of 2017. So I'm very familiar with that process and what its likely outcomes are going to be. I think that my concern with the NHI framework is that it is very often framed in very simplistic terms, as if we're going to do this, we're going to do that, we're going to contract like this, we're going to give people that money. We're going to assume that we're going to raise an enormous amount of money which will buy the whole health system. That is the fundamental assumption behind the NHI proposal itself. And there are a number of constraints to that proposal, the fiscal constraint being only one. The other being the institutional design, which proposes to centralize two key functions within government. One which is appropriate and which we already do, which is the pooling function. When we pay taxes, you're effectively paying, you're introducing a very substantial vertical cross-subsidy from high-income people to low-income people, and that's what the tax system does. How we allocate that money, and if we allocate it imperfectly, it is our fault as government. So the pooling system is distinct from the purchasing system. The purchasing system at the moment is in two broad realms. It's in the provincial structures and it's in medical schemes at this point in time, largely driven on contract with medical scheme administrators. That is our system as it exists. In terms of the universal coverage objective, South Africa technically complies with universal coverage because everybody has some access to prepaid healthcare one way or another. It is not entirely perfect and there are lots of gaps within it, but there isn't essentially a universal coverage gap in South Africa, which is evidenced by the very low out-of-pocket expenditures that we detect overall on South Africa's national health accounts. That is not necessarily an endorsement of the South African health system, which in both the public and the private sectors is failing. Now, I want to be very clear about why it's failing and who's to blame. The health market inquiry's assessment on the private sector failures are market failures. Market failures which can make people rich because of how we regulate that system. If you fail to regulate it properly, that is an outcome. If we fail to regulate the public sector properly, the outcome is very high maternal mortality ratios, disgusting performance at a provincial level, and structural underperformance for the amount of money that is being spent. That is a failure of our governance framework, and our private sector has a failure in terms of the governance framework as well. Who's to blame? It's not the private sector to blame, because in all health systems, governments regulate private sectors, and we have failed to do so properly in South Africa. We have also failed to regulate the public sector properly, and we have allowed in the creation of the in the establishment of the public health system, we have institutionalized corruption largely through the gap created by political appointments into running the health system. We have a very similar model operating with regulators as well, which means that the regulation of the private sector is also contaminated by institutionalized corruption. Now, the important question to ask in the sort of universal health coverage debate that we're having in South Africa is, why aren't any of those issues on the table? Why are we not looking at those issues? We're having an esoteric discussion about multi-payer versus single payer. And I can tell you now, no matter what anybody puts in a bill, 5 years from now, we're still going to be sitting with a multi-payer system and two systems, both our provincial system and our medical scheme system, and both will be working worse than they are even today, because we will have done nothing to address their systemic failures. 10 years from now, it will be worse, and we still won't have a so-called single-payer regime. One of the reasons is it's technically impossible to introduce. So firstly, the idea of a single-payer regime is, within the South African context, is understood to be possible if you can raise taxes equivalent to about 3 to around about 4% of GDP, over and above current tax levels. So that is the presumption, because if you don't raise that amount of money, there is no money for this contracting that would occur, other than what's already in the public sector. So it's well understood that within the context of public finances, general taxes reach a limit in accordance with the tax bases that they are focusing on. So personal income tax, VAT, corporate taxes, various excise taxes hit what are called Laffer curve limits. There's an amount at which when the tax rates go up, the government revenue actually goes down. So there's a limit that is reached. That is a technical limit. So if we assume that we are going to fund one payer for all of healthcare in South Africa, and that's going to be our sole mechanism by which we institutionalize social guarantees for healthcare, we are in trouble, because we will not raise anything more than we're currently getting now. So now you have to ask yourself, why is there no financial feasibility report on the NHI? After 11 years, I'm telling you now, this is my background, my stuff. In 11 years, I could have produced 15 bloody reports on on the financial feasibility and risk analysis. Why is there not one? Why has Treasury not published a report? Why is there no institutional feasibility assessment? This is a very big proposal. It's proposing to rip up the provincial structure, rip up the pre-existing system in medical schemes, put them in one organization, and assume it's going to be better than those two. So you would want to know, is it feasible? What are the risks? What's the possibility of this not being achieved? Now, I would want to see that that's done. Now, to date, with the bill having gone to Parliament, not one report produced on that. We've spent 3.8 billion rand on pilot projects, which didn't even test the institutional mechanism. It didn't even test the design of the national health insurance structure. It's an institutional proposal. Now, given that I've just got 10 minutes, I will move on to the issue that was mentioned of institutionalized corruption. I pointed out that the institutionalized corruption which we see today, we can see it in the Auditor General's reports for all of the provinces. Gauteng managed to have 6% of its budget classified as irregular expenditure by the Auditor General. Free State, 11%. So the person running the Free State gets a promotion to the top 6. That's the kind of stuff that's happening in our system. It's the gap that is created by political appointments which allows people who are not part of government to organize, to infiltrate the structures of government and to access tenders, procurement, appointments. Now note that the National Health Insurance Fund proposal involves all of those. It involves an additional component which is licensing, the Office of Health Standards Compliance. The National Health Insurance Fund procures. The intention is to procure, it won't, but the intention is to procure in today's value terms 450 billion rands worth of funds. That's a lot of money. That's a lot of power concentrated in the hands of a single organization. Now, I would expect that somebody would have assessed the institutional risk of having one person appoint the entire board, appoint the CEO, appoint the entire board and appoint the CEO of the Office of Health Standards Compliance. So they're the gatekeeper to whether or not you could theoretically contract with this organization is essentially a political appointment. The same person has appointed everybody across the entire system, which means that accreditation. If you don't get accreditation, you can't contract. What do you think is going to happen there? Look at Zondo. In the case of contracting and purchasing from the central fund and procuring supposedly everything, it's also going through a single gatekeeper. That's a very high risk given South Africa's context. And for some reason, people are making this distinction between a particular section of the Public Finance Management Act that this would be, it's not a state-owned enterprise. It's a governance structure you talk about. SASSA, when it was created which allowed the Minister of Social Development to approve the tenders. What do you think happened? We've only caught the last minister. She's not in jail. We only caught the last minister on that tender. The previous ministers have also been implicated from day one with SASSA. And you know what they argued with SASSA? That they didn't want a board and an independent board, and I was part of the Taylor Committee of Inquiry which made the recommendations on the social security reform frameworks in South Africa, and the recommendation was for an independent board. No independent board because we want the SARS model. This has been the proposal also consistently in the NHI fund. We want the SARS model, because SARS works so well. Well, look at the SARS Commission and the Zondo Commission. It took one president appointing a range of people across a series of state-owned enterprises to effectively capture billions of rands worth of government's capabilities. It's procurement all falling under those powers. And SARS was now shut down, structurally changed, to avoid actually doing its job. So the SARS model has a very thin governance model and cannot, and what we're proposing for the NHI is the same. What do we expect? I expect exactly the same. Then I'll make a further point, the issue of the provincial powers and structures. It's going to be a court case, so we can see what comes out of that. I mean, it's going to court. But if the bill proceeds in any way. But the issue is that the way in which the provincial structures are established, they're established in terms of the Constitution. The provincial equitable share allocation, which is allocated as revenue to the provinces to legislate on, essentially involves a very large unallocated block grant. And the purpose of that block grant is in lieu of tax revenue that the provinces would have raised themselves. So Gauteng, if we had allowed the provinces to raise the revenue themselves, Gauteng would get the lion's share and the other provinces would get very little. So the provincial equitable share is a substitute for a mechanism called a tax capacity equalization mechanism, which is where the provinces would have raised their own taxes and equalized amongst themselves using a formula. The simpler method was let national raise the taxes and then allocate them back as an unallocated block grant. Those are effectively provinces' taxes that are being allocated back. It receives also conditional grants which are meant to be allocated on the basis that they are performing certain national or supra-regional functions. That's how our constitution is organized and structured. If the assumption is that we're going to remove the provincial equitable share allocation and give it to a national fund, the provinces no longer receive that money as revenue. They receive it as reimbursement to the providers, which means that the legislature does not budget those funds. That means that the provincial powers that have been allocated in terms of the Constitution have been circumvented. That is going to court. The proposers of this will lose that particular battle because the powers are allocated by the Constitution and it is not up to a single law to alter it. And effectively, provincial governments are going to become, provincial hospitals and provincial health departments are going to become agents of a national fund, and they will not be effectively utilizing the powers that are allocated in terms of the Constitution. So this will be a big issue. These are major obstacles. They haven't been thought through. It's a very superficial proposal. And the problem is that you cannot just convince people by promising what's going to happen when you can't actually demonstrate rationally how.